Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
A 30-year-old male patient with T1cN2A invasive ductal carcinoma of the left breast, ER/PR positive, HER2 negative, following 4 cycles of dose-dense doxorubicin, cyclophosphamide, and docetaxel. The patient is morbidly obese. We're going to cover the presentation in a bit, but given the obesity and the presence of the left-sided disease, what radiation therapy techniques are recommended, presumably to have, avoid cardiotoxicity, and what systemic or endocrine therapy regimen is going to be recommended in the adjuvant setting. So this patient presented with a palpable lump for approximately 6 months, but did not undergo evaluation due to barriers with access to care and related to insurance. He has a good performance status. He is morbidly obese with a BMI of 60, type 2 diabetes, which is poorly controlled with a hemoglobin A1C of 11, no significant alcohol or drug use, no family history of breast cancer or other cancer history. We're going to talk about the imaging here in a bit. We might just skip to that, and Dr. Chalkelson will let you walk us through this.
So we have a mammogram, and what you can see is that there is a little bit of excess soft tissue here. It's hard sometimes to differentiate gynecomastia from cancers. In some cases pretty straightforward, but here you see this associated with retraction of the skin, and there is skin thickening. This is definitely abnormal on the mammogram. So there's more than just a tumor within the breast, and I think we have the MRI images next. Oh, no, I'm sorry. So he had a PET scan. You can go back if you want. Anyway, the PET scan just, and this is not even a fused image. You can just see that he has uptake in his breast, and he also apparently had a positive lymph node, which you can kind of see here. And then here's his MRI. And I think the important part of this is that there is a lot of abnormal enhancement within the breast, but he also has enhancement in the skin. And some nipple retraction. So this tumor does extend all the way into the skin. And apparently he did have epidermal involvement.
Okay. And so he received neoadjuvant systemic therapy with 4 cycles of dose-dense doxorubicin, cyclophosphamide, and docetaxel. The MRI after neoadjuvant treatment demonstrated reduced size of the known left breast cancer and no residual lymphadenopathy. He subsequently underwent a left breast radical mastectomy, which demonstrated residual invasive ductal carcinoma, which was poorly differentiated, measuring 16 millimeters with involvement of the epidermis. The margins were negative, the closest one being 2 centimeters. Unfortunately, there were found to be 9 out of 12 lymph nodes positive for metastatic carcinoma, and there was presence of extranodal extension. So the final pathologic stage there after neoadjuvant therapy, T1cN2A. So given the patient's comorbid condition of morbid obesity, as well as the presence of the left-sided disease, what radiation therapy techniques are recommended? Dr. Muccini, do you want to walk us through that?
If you have an hour. Oh. So to begin with, there's equipment issues, right? The patient weighs 400 pounds. Some of the simulators, the tables, do not will not tolerate greater than 350 pounds. So you'd have to be sure he's on the correct simulation in your department. The linear accelerators tables usually can handle up to 450, but that's one of the first things. Secondly, of course, this patient needs comprehensive regional nodal radiation therapy, including the IM nodes with 9 out of 12 nodes positive. It's left-sided. The patient's already going to have difficulty with radiation because of the diabetes, BMI. So a couple of things. To start off, we need to take into consideration to protect the heart in some way. And usually what we've been familiar with using at our centers is the active breathing control device, which assists the patient in holding their breath and timing the radiation when they've held their breath for 10, 15 seconds. So that may be needed. Otherwise, may have to do some form of gated therapy. With respect to some of the other techniques that'll be necessary, because of the large size, probably going to have to use intensity modulated radiation therapy to cover the chest wall, the regional lymphatics. There's such a huge separation, and probably going to need some combination of higher energy beams. I know this is very technical, but nonetheless, it does require a lot of the more sophisticated approaches towards comprehensive regional nodal radiation therapy. In addition, this patient is going to have some issues related to potentially developing lymphedema. I can't really stay off the axilla levels 1 and 2 because of so many nodes positive. And certainly with the high BMI and 12 nodes out and then comprehensive radiation therapy, that's a potential problem. So long and short of it is we need something to address the heart, protecting the heart, the active breathing control device, the utilization of some more sophisticated techniques such as IMRT, which most centers have, higher energy beams, and just a little bit more sophistication treating this patient.
Would you treat him supine because you need to do all the nodes, or can you treat him prone? Or
that you can treat the regional nodals in prone position. It's a little bit more difficult. Very few centers in the country do it. We don't do it, but nonetheless, it can be done. In my center, we would treat them supine, use the active breathing control device if necessary, and that would be the technique. But yes, you can use the prone position. This patient, though, it's not a large pendulous breast where the prone technique would be advantageous. This is more of a large separation, and so I think of the supine technique would work better. It's a good question, though.
Frank, is there any advantage to proton therapy for a patient like this? Or
well, you'd have to see technically. I mean, if covering the IM nodes in this patient, you'd have to see if there's any advantage. I mean, those studies are ongoing right now, trying to elucidate the particular anatomy and the particular situation where protons will help. But I think with the ABC device, the active breathing control device with IMRT, I think that pretty much can match any proton therapy with respect to technology and techniques. But again, we'll see. We're collecting a lot of data right now across the country. There's over, I think, 30 centers that are participating in the NRG right now, address more or less a registry looking at those clinical situations where protons are better technically. But for the average patient, definitely can use ABC with IMRT. Remember that the advantage to protons are strictly technical. They're not biologically any better. They have roughly the same RBE, the radiobiologically effective dose. So it's really just, for those physics people among us, it's the Bragg peak and the ability for the radiation to stop at a certain distance and use that to your advantage.
I see. Dr. O'Shaughnessy, do you want to comment about systemic therapy in this very high-risk patient?
And I think his germline status is negative. It's been queried, right? And it's negative, I think it said. So,
That's correct.
He's a grade 3, poorly differentiated breast cancer, a lot of residual disease. Again, going back to what I said before from the CREATE-X, the entire study was positive, and the point estimate was 0.88 in the ER positive, and our data, showed it was the more highly proliferative that benefited. So again, because of the high risk status, I probably would offer him 6 months of the capecitabine. The issue for this gentleman is the fact that the host issues with regard to the morbid obesity and the hyperinsulinemia, the inflammatory state, the high estrogen levels because of the adiposity. These are very, very important issues that are likely to influence his outcome. The issue is we don't have, aside from, of course, endocrine therapy, we don't have level 1 evidence that helping him with reversing glucose intolerance and hyperinsulinemia, for example, with bariatric surgery, for example, we don't have level 1 evidence that would be beneficial to him. We certainly have prospective randomized trials going on looking to see whether a 10% weight loss in the setting of, obesity will be beneficial to our early stage breast cancer patients, but we don't have those data yet. Interestingly, there are data, the bariatric surgery patients are followed in large registry trials for many, many years. And there are data that the patients develop fewer primary breast cancer, fewer primary cancers, I should say, with bariatric surgery. So, it's as you would expect. These are important growth factors, the inflammation, the insulin. So that would be very much in my mind with this gentleman. And I would want to be, talking to him about, the possibility of some bariatric surgery, et cetera. But from an endocrine therapy standpoint, if he were a woman, I would be looking for, ovarian ablation and an aromatase inhibitor. However, in men, the testes make about 20% of the estrogen. The testosterone in the testis is converted by aromatase to estrogen, and that's 20% of the male production of estrogen. The rest of it is through other tissues, adipose tissue, bones, brain. A lot of tissues have that aromatase enzyme. And so I don't like the idea of an aromatase inhibitor for him, even with the LHRH agonist, which would be required, because otherwise you get pituitary feedback. If you lower the estrogen with the aromatase inhibitor, the pituitary doesn't see enough estrogen, and so it really pumps out the LH and the FSH, and that will drive the testis to make more testosterone converted to estrogen. So he'd have to have testicular suppression with an LHRH agonist. But in his case, in spite of the grade 3 biology and the high risk, my recommendation to him would be tamoxifen, so that tamoxifen can block the receptors and we don't have to worry about adequately lowering estradiol levels in a man that's morbidly obese. We have very little data anyway with an LHRH agonist and an aromatase inhibitor. In men, we have much more data with tamoxifen, but particularly in a morbidly obese, I'd be so concerned that the aromatase inhibitor would not be adequately effective at getting down the 80% of the estrogen that's going to be produced in the peripheral tissues. And then, of course, I would offer him zoledronic acid.